evening, everyone. Thank you for joining our webinar tonight. I would like to introduce Dr. Neelima Thakur with the Northeast Regional Epilepsy Group. She will be presenting epilepsy in elderly. There will be no question and answer session tonight. However, should you have any question, please email them directly to me, and I will forward them to Dr. Thakur. She will provide you with an answer. Again, thank you for coming to our webinar. Dr. Thakur?
Thank you, Tijan. Good evening, everyone. Welcome to the webinar. And today I'm going to talk about epilepsy in elderly. Epilepsy in elderly has gained significant importance in the last decade, predominantly because the research has shown that incidence of epilepsy is higher in elderly, although in the past it was thought that epilepsy was predominantly a childhood disorder. And also is the fact that epilepsy is one of the most common serious neurological disorders in elderly, after stroke and dementia. These are the U.S. Census projections for population increase over the next 50 years from 2000 to 2050. So as per these projections, overall the general population is going to increase by 49% in 50 years between 2000 to 2050. And when you look at the elderly population, that is the population over the age of 65, there is going to be a 147, which is a humongous percent increase compared to what it was before 2000. So in the next 50 years or so, we are going to see a very significant increase in the elderly population. Elderly people are with epilepsy. It's a large group. I would come to the numbers in the next coming slides, but also is the fact that it's a neglected group, mainly because of lack of information, even in the medical care sector. A postal survey that was done by a study group showed that 25% of the general practitioners, they were unaware that epilepsy could actually start for the very first time in elderly. So how common is epilepsy in seniors or patients above the age of 65? So as you can stand out, the prevalence and incidence of epilepsy is higher in later life, and approximately 7% of seniors have epilepsy. And of all the new cases, 25% of those new cases occur in elderly population. This is the most quoted study which was done in UK. In UK, there's a epilepsy registry where all the epilepsy patients are registered, so they have a very robust data. This slide shows the prevalence of epilepsy. Prevalence means the total number of cases which are old patients and new patients with epilepsy for that year. So here the prevalence overall in general population was 5 out of 1,000 people had epilepsy, and then they classified into children and elderly. So here you can look at the numbers. The numbers are significantly high in elderly, and they reach higher numbers as the population ages. For example, children between the ages of 5 to 9, the prevalence is 3.16 per 1,000 people. In patients between 65 to 69, the number is almost double, 6 per 1,000 people. And in patients above 85 years of old, the number increases further to 7 per 1,000 population. So the prevalence is once again, as I had mentioned before earlier, that it's higher in elderly population. Incidence of the new cases per year, and the total incidence of epilepsy patients was 80 for 100,000 people. And again, the numbers were significantly high in the elderly. As you can see, between 65 to 69 years, 85 out of 100,000 people had epilepsy. And when the numbers keep on increasing, and above 85 years, 135 out of 100,000 people have are new cases of epilepsy. What causes seizures in elderly? Well, we can classify these causes as we can in any age group into provoked seizures and unprovoked seizures. The most common causes are cerebral infarction or stroke, arteriosclerosis, head trauma, and other causes which include dementia, tumors. Stroke is the leading cause of new onset epilepsy in elderly, and studies have shown that hemorrhagic strokes have a higher risk of causing seizures compared to non-hemorrhagic or ischemic strokes. 8% of patients with hemorrhagic strokes will develop seizures within the first 2 weeks, while 5% of patients with ischemic strokes will develop seizures in the first 2 weeks. And post-stroke epilepsy can occur at any point in life. However, it's mostly common within 3 to 12 months after the stroke. The second most common cause for epilepsy is dementias and neurodegenerative diseases. 10 to 20% of all epilepsy in older people have dementia and neurodegenerative diseases. So epilepsy is common in dementia patients. However, the opposite is also true, although it's less appreciated, that dementia develops with greater frequency in patients with already established epilepsy. So the vice versa is also true. Post-traumatic epilepsy is also common in elderly for a few reasons. One, head injuries are very common, mainly because of falls, and they cause up to 20% of epilepsies in elderly. The increased risk of head injuries is mainly because of patients being on anticoagulants and blood thinners and platelet inhibitors, which increase the risk of subdural hemorrhage. Not all head injuries will lead to epilepsy. The factors that increase the risk are: number 1, loss of consciousness; number 2, amnesia after the fall for greater than 24 hours; number 3, if the head injury involves a skull fracture or a contusion to the brain or a subdural hematoma. Seizures can be a presenting feature of tumors at any age, and the most common tumors that can cause seizures are gliomas, meningiomas, and metastasis. Sometimes seizures may be the first presentation of a metastatic disease. One study showed that 43% of those presenting with seizures from a metastatic disease had no previous diagnosis of a cancer. So seizures can actually lead to a diagnosis of cancer. Coming to provoked seizures are also called acute symptomatic seizures. These seizures do not fall into the definition of epilepsy, and they're often reversible, and they're usually time-linked or associated with an acute cause. The most common causes are alcohol withdrawal or any metabolic or electrolyte disturbances like hyponatremia, low sodium, low calcium, low magnesium, any systemic or any central nervous system infections. Some of the drugs that are commonly prescribed to patients, mainly elderly, can also provoke seizures. For example, tramadol prescribed for pain, antipsychotic medications, antidepressants, antibiotics, predominantly quinolones, which are mainly used for urinary tract infections. They can provoke seizures. Some of the other medications, theophylline, levodopa, diuretics, can also provoke seizures. However, these are reversible. So how do the presentation of epilepsy in elderly differ from the other age groups? Sometimes the presentation can be challenging in elderly because most often it is less specific. It is not as typical of a seizures as you can see in the younger age groups or the children. And that's the reason it takes time to come to a firm diagnosis. And underdiagnosis and misdiagnosis are common. %70 of the seizures are usually of focal onset, and the most common presentation are memory lapses, episodes of confusion, or sometimes periods of inattention and apparent syncope. A late onset generalized epilepsy, idiopathic, meaning myoclonic seizures or absence seizures, is very rare but can occur. Status epilepticus is a serious condition where seizures are prolonged or there are repetitive seizures. It is a life-threatening emergency, and this is common in elderly population. The annual incidence of status epilepticus in above 60 years patients is 86 out of 100,000. It is almost twice that of a general population. And also, over half of the patients with status epilepticus do not actually have a previous diagnosis of epilepsy, and most of the times this is usually precipitated by an ongoing acute illness, metabolic imbalance, or infection. So this is a graph where, as you can see, the overall incidence is around 40. But when it comes to the elderly, the number almost doubles, to going above 80, 86. And also, the deaths are higher in elderly compared to the general population. The causes of status epilepticus are not much different from the other causes of seizures. The most common causes are strokes or cerebrovascular accident, or even prior history of stroke, low anti-epileptic drug concentrations in patients who are already diagnosed with epilepsy. Hypoxia or cardiorespiratory arrest can also cause status epilepticus. Metabolic imbalances, infections, tumors, trauma can all present with status epilepticus. Non-convulsive status epilepticus is a unique type of status epilepticus which has been increasingly diagnosed mainly because of increased EEG monitoring, long-term EEG monitoring, and patients with altered mental status or confusion. And it accounts for about 4 to 20% of all patients of status epilepticus. Only 1/3 of the patients with non-convulsive status epilepticus actually have a history of epilepsy, and it carries a very high mortality of about 50%. A study done by Veteran Affairs, called Veteran Affairs study, found that 65% of patients with non-convulsive status epilepticus died within 30 days of an episode, compared to 27% of patients with generalized convulsive status epilepticus. So what's the difference between a non-convulsive and generalized convulsive? As the name suggests, in a non-convulsive status epilepticus, the patient does not present with the typical seizures where the patient is convulsing or having other usual features of seizures. Here the patients usually present with impairment of cognition or behavioral changes, agitation, excitation, or very subtle facial or limb twitches, or they can also present with aphasia, language disabilities, or head or eye deviation, or just autonomic disturbances, meaning changes in heart rates or blood pressures. And when EEG is done in these patients, the EEG shows abnormalities that is consistent with seizures or status epilepticus, and this is called non-convulsive status epilepticus. Coming to diagnosis, the most challenging part in seizures or epilepsy in elderly is to diagnose whether it is a seizure or not a seizure, because there are so many other conditions or medical illnesses that can masquerade as a seizure, or the seizure might be undiagnosed because it might be diagnosed as some other condition. This is a list of differential diagnoses. The most common neurological differential diagnoses are TIA or transient ischemic attack, transient global amnesia, migraines, narcolepsy, restless leg syndrome. Cardiovascular vasovagal needs to be ruled out, orthostatic hypotension, arrhythmias of the heart, any structural heart diseases have to be ruled out. Metabolic hypoglycemia, low glucose, low sodium, or low potassium hypokalemia can also are also in the differential diagnosis. Sleep disorders can also mimic as seizures, so these need to be ruled out. And psychogenic or psychological events are also not uncommon in elderly. Coming to diagnosis. Diagnosing epilepsy is more challenging and difficult, and actually also more time consuming in elderly. Like I said, because of atypical presentation and a whole plethora of mimics, and also because of the higher prevalence of other comorbidities. Delayed diagnosis is very common. Studies have shown that only 24% of patients who were initially presented to the doctors, they were diagnosed with epilepsy. And it took an average of about 19 months from the time of first seizure to be diagnosed correctly with epilepsy. Diagnosis, it requires the usual steps where a detailed history is very important, clinical examination to rule out other possible causes, investigations including blood work, and when cardiac causes are in the differential, then EKG, heart rate monitoring, and possibly a tilt-table test can be helpful. Chest X-ray, and EEG, and neuroimaging studies, meaning a CAT scan and an MRI of the brain when possible. How do you treat epilepsy in elderly? For provoked seizures, treating the underlying cause would resolve the seizures, and these are not diagnosed as epilepsy, and they're reversible. For unprovoked seizures, the first treatment, or the first mode of treatment, is anti-epileptic drug treatment. This flowchart gives an idea of the usual or the most common protocol followed by most of the neurologists or epilepsy specialists when diagnosing a patient or treating a patient with seizures or epilepsy. So as you can see here, if the history is suggestive of an epileptic seizure, then you investigate, and when you investigate, if it is confirmed then that it is a first seizure, which is the next box that you see below, history suggestive of epileptic seizure. Then if you're sure it is a first seizure, then the next thing that needs to be characterized or analyzed is there a risk of relapse? If the risk of relapse is high, meaning if the EEG is abnormal or if there is a structural abnormality in the brain, which can be seen in a CAT scan or MRI, then the risk of seizures is high. In those patients, you start appropriate treatment. In patients who have had a first seizure, and if the risk is less than the benefit, then they are just observed and anti-epileptic medications are not started. Do we start treatment after a single unprovoked seizure? This remains controversial. In young, it's relatively easy. The usual norm is if there is a first single unprovoked seizure and if the MRI and EEG comes out normal, most of the times the usual norm is to observe and wait for a second seizure. If there occurs a second seizure, at that point the patients are placed on anti-epileptic medications. However, in elderly, sometimes patients might be started on an anti-epileptic medication even after a first seizure, and there are a couple of reasons for this. One is older people who have presented with the first unprovoked seizure, they're more likely to develop a recurrent seizure than younger adults. And also in 60% of the elderly people, most of the times a cause is identified. The good news overall is epilepsy patients, the elderly epilepsy patients respond well to treatment compared to other age groups. As you can see in this graph, as you age, your response to medications is higher compared to when you're young. Studies have shown that up to 80% of patients with onset of seizures in their old age can be expected to remain seizure-free with seizure drug treatment. Treatment decisions have to be made cautiously in elderly because elderly population are more susceptible for adverse effects compared to young adults, and also the pharmacokinetics and pharmacodynamics are different for the same anti-epileptic drugs in elderly and in the young population. And also is the fact that most of the elderly are on multiple medications, so the interactions between medication to medication will be an issue. As I mentioned before, pharmacokinetic and pharmacodynamic, meaning the absorption and the way the medications are metabolized in the system, is different in elderly. There is decreased absorption, and there is because of delayed emptying in the stomach, and also increased time in the intestines. At the same time, because of changes in the metabolism and the proteins in the body, the transportation and the metabolism is also decreased in elderly. So all these have to be kept in mind before starting on an adequate dose of anti-epileptic medication. So what would be the general prescribing principles? Well, this is the most common prescribing norms which are recommended. It's reasonable to assume in an elderly patient that the patient is going to be on the medication for lifelong. So an ideal medication of choice would be a medication which would achieve a freedom of seizures with very less side effects. And it's well tolerated, and it's easy to dose, and is free of drug-to-drug interactions. And also, the golden rule is always start on a lower dose of medicine and titrate it up if necessary to control the seizures. Which medication works better? For this, we have very limited data at this point of time, and so it's not possible to come to a conclusion that one anti-epileptic medication would work better than other. This slide shows the older anti-epileptic medications and some of their usual uses and the most common side effects. Benzodiazepines, I'm sorry, this is the slide. Benzodiazepines, meaning Valium, diazepam, Diastat, are mainly used to acutely control seizures or in emergencies like status epilepticus. The side effects are psychosis and sedation. Phenobarbital has a broad spectrum of action. It can be used as a once daily dosing, but it again has a side effect of sedation. Phenytoin or Dilantin can also be used, but it has significant interactions with digoxin and warfarin, and also is an enzyme inducer. And also the Z-order kinetics of Dilantin have to be kept in mind, as the physician has to be very careful in making these changes. Carbamazepine is the medication that is effective for partial onset seizures, but in elderly it has to be used very, very carefully because it has a side effect of causing hyponatremia. I'm sorry, the slides are flip-flopping here. I think they're back to the slide. So carbamazepine is useful in partial onset seizures, but again, it has an enzyme inducer action, and it also causes hyponatremia, which can occur in higher frequency in elderly because most of the elderly are on diuretics for blood pressure or because of cardiac failure. Sodium valproate or Depakote also has a broad spectrum of action. It has fewer interactions. However, it can cause some reversible extrapyramidal symptoms and can also cause sedation. These are the newer medications. Lamictal, it's very effective. It also has a more stabilizing action. However, it needs to be used very carefully in patients who are taking sodium valproate, and also it has a risk of causing an allergic rash, so it needs to be titrated up very slowly over a period of 6 to 7 weeks. Oxcarbazepine belongs to the same group as carbamazepine but has fewer side effects. Still, it can cause hyponatremia, so does it needs to be started carefully in elderly and in patients who are using diuretics. Keppra has an inert metabolite combination. However, the most common side effects are mood and behavioral problems. Topamax can be used in patients with seizures and migraine prophylaxis, and it can also cause weight loss and cognitive problems. So each medication has its own benefits and its own side effects. So overall, in summary, whenever the best way to put it is there are lots of seizure medications available, and at this point we do not know which medication works better than the other in elderly population. However, overall comorbidities of the patient has to be kept in mind. So if the patient has any other neurological conditions or if the drug can be effective, like for example, gabapentin can be used in a patient with epilepsy, but it can also be used in neuropathic pain, and it can also be used in a patient with liver dysfunction. So in any patient with these conditions, that are diabetic neuropathy with liver dysfunction and who has seizures, gabapentin would be a medication to use. The challenges of treatment are comorbidities. They add to a diagnostic challenge, and they also complicate the treatment options. And because of polypharmacy, too many medications, drug-to-drug interactions are very common. A survey done in a nursing home showed that, in nursing home patients, showed that 49% of the residents were on 6 or more medications when they were receiving anti-epileptic medications. So drug-to-drug interactions plays a very significant part in managing anti-epileptic medications in elderly. The other options when medications are not effective is surgery and vagal nerve stimulation. At this point, we do not have a specific data for elderly population with regards to these two management options. However, surgeries have been done in patients in elderly above 65 years, and the success rate, which is usually quoted for example, for a temporal lobe surgery, lesional temporal lobe surgery is 60 to 80%. And for vagal nerve stimulator, the responder rate is that is greater than 50% of seizure freedom is 40%. So in summary, development of epilepsy is common in elderly. The number of patients with epilepsy will significantly rise in the coming years and would be a huge burden for on healthcare resources. Epilepsy can have a physical and psychological impact in old age with a substantial negative effect on the quality of life. A physician or a clinician has to be aware of the mimics while treating or managing epilepsy patients. And epilepsy patients respond well to treatments, and most of the epilepsy patients remain seizure-free with appropriate treatments. Attention should be paid to potential side effects and for drug interactions for starting epilepsy patients on seizure medications. So this is the brief summary which I just mentioned, and hopefully this talk was helpful, and as always we hope that epilepsy patients, no matter what the age is, they always remain happily seizure-free ever after. Thank you very much.